Welcome back to the deep dive. Our mission here is, as always, sharp and singular. You bring us the sources, those dense, fundamental texts like Baily and Love, and we bring the interpretation.
Right. We're here to pull out the high-yield summaries, give you some memorable anchors, and really act as your ready reckoner.
A revision companion, really, so you can solidify your grasp on these complex concepts without just, aimlessly rereading a chapter.
And today, we are tackling a huge one, a really critical surgical topic, day case surgery. Specifically, we're diving into the insights from Chapter 22 of the 28th edition of Baily and Love.
And for any of you listening, for any medical learner, it's essential stuff because day surgery is basically the default standard for elective care now.
It is. It's where the system is at.
Exactly. So this isn't just about a clinical skill, it's an operational necessity. Day surgery, or ambulatory surgery, it's where modern surgical volume has to meet efficiency and, of course, patient preference.
To gain this whole complex process as structure, we thought we'd anchor our discussion today around a metaphor.
We're going to call it the surgical express lane.
I think that's a perfect analogy, because express lane immediately makes you think high throughput, high volume, but absolutely zero tolerance for error or delay.
Great. A single stall in that lane and the whole system backs up.
Precisely. To make it work, every single factor has to be tightly controlled. The express lane needs precise traffic control. That's your patient and procedure selection.
It needs high-quality, fast-acting fuel.
Which is your sophisticated anesthesia. And crucially, it has to guarantee a safe exit. Those are your non-negotiable discharge criteria. If any one of those fails, the patient gets forced off the express lane and into what you might call the inpatient gridlock.
Okay, so our goal for this deep dive is to extract and really elaborate on the key mechanisms that make this express lane run smoothly, all straight from the source material.
We'll map the pathway, define the surgical guardrails, explore the patient checkpoint for medical suitability.
And we'll get into the logistics, the dedicated facilities, and that rigorous discharge process. We also need to touch on how this whole model is being adapted for acute emergency cases.
Definitely.
So let's jump in and define the parameters of this express lane.
Let's do it.
So starting right at the fundamentals. In medicine, definitions really matter, don't they? They dictate resources, they dictate how we categorize patients. So what exactly qualifies as day surgery in the modern sense?
The UK definition, which is the standard used in the chapter, is very, very precise. It's the admission of a selected patient for a planned surgical procedure with the patient. And this is the key phrase, returning home on the same day.
The same day. That simple phrase is the entire threshold.
It is. And here's the core anchor for every learner out there. Day surgery is strictly in by dawn, out by dusk. If that patient's stay hits midnight,
It's not a day case anymore.
it is not a day case.
Yeah.
And we have to draw such a firm line at that calendar day for a very practical reason.
Why is that? Why the hard cutoff?
Because the moment that patient crosses the midnight barrier, they move into a completely different classification. They become an inpatient, or what's sometimes called a 23-hour stay, even if they leave just an hour later.
And that changes everything, I assume.
Everything. The resources used, the nursing documentation, the financial coding, it all shifts. So true day surgery, as defined here, has to involve procedures that need full operating theater facilities and/or a general anesthetic.
So we're excluding the really simple stuff.
Right. We're not talking about simple outpatient clinic procedures or routine diagnostic endoscopies that don't need a full theater. Those were never going to be an inpatient stay anyway.
So we're focusing on pretty complex procedures that have been surgically and anesthetically optimized to avoid needing an overnight bed, which brings us to the double benefit, the why it matters. Why has setting up this express lane become such a critical priority for health systems all over the world?
Well, there are two massive, equally important pillars of benefit here. First, and most importantly, are the patient benefits. Being able to recover at home, in your own environment. It drastically improves comfort and mental well-being. It reduces the stress of being in a hospital.
It also minimizes all the domestic disruption, letting you get back to your normal routine much faster.
And this is vital. It significantly reduces the patient's exposure to, and therefore the risk of acquiring, a hospital-acquired infection, an HAI, things like MRSA or C. diff.
That's a huge concern on high-acuity acute wards. That risk reduction alone is a massive public health driver.
It is. But then you've got the other pillar. For the hospital administration, this is an efficiency goldmine.
I can imagine.
Absolutely. I mean, beyond boosting patient satisfaction scores, which are always important, the main operational benefit is freeing up that inpatient capacity.
Right. Every successful day case frees up a bed.
It frees up a bed, potentially for 24, 48, even 72 hours, depending on what the typical length of stay for that procedure would have been.
Which
means we can then use those freed up beds for the higher acuity, more complex medical or surgical cases. Maybe someone who needs HDU monitoring or complex medical stabilization.
So it's an essential strategy for optimizing the flow of a modern hospital.
It's literally keeping the hospital from drowning in gridlock. It's about getting the right patients into the right beds at the right time.
Okay, but to achieve this, you need a detailed roadmap. The chapter illustrates this as the day surgery pathway in Figure 22.1. This can't just be left up to the surgeon and the anesthetist on the day.
Oh, far from it. This pathway is a really high-quality process that's supported by the entire multidisciplinary team, the MDT. The steps are crystal clear.
So what are they?
You start with booking, you move through a really rigorous preoperative assessment, then admission, the surgery itself, discharge, and finally, and this is often forgotten, comprehensive day surgery follow-up.
Let's focus on that team aspect. When you say an effective MDT, who is actually taking the lead at each of these steps?
Well, the MDT is absolutely crucial. The pre-op assessment, for example, that's typically led by specialist day surgery nurses. They're highly trained to triage medical fitness and social needs.
Then the surgeon and anesthetist add their bit.
Right. They contribute their specific risk assessments. Then, during admission, surgery, and immediate recovery, you have the expert theater and recovery staff making sure that fast-acting fuel, the anesthesia, is delivered safely.
And post-operatively?
Post-op, it's the nursing team that handles that critical discharge phase, and they do it based on very strict objective criteria.
So the core enabler for this whole pathway to succeed is really having specialized staff.
Precisely. The pathway has to be seen as a system-wide priority, and that demands experienced, expert staff and the right resources at every single stage.
And that expertise ensures that any little deviation from the plan can be managed instantly.
Yes. A slightly longer recovery time, a bit of post-op nausea. They can manage it effectively to guarantee that safe and successful discharge happens. And the staff have to be experienced in day surgery specifically. A nurse who's used to complex critical care might not have the rapid assessment and turnaround skills needed for high-volume day surgery.
Okay, so the takeaway here seems to be twofold. First, day surgery is defined by in and out the same calendar day. And second, its success just hinges on a dedicated expert MDT and the critical resource management benefits it provides to the wider hospital.
That's it in a nutshell.
All right, we've defined the express lane and the team running it. Now we need to define the cargo. What can actually go on this lane? Section 2 is all about surgical suitability.
And as you mentioned earlier, technology has allowed this to evolve dramatically.
How so?
Well, the huge shift toward minimally invasive surgery, enhanced recovery protocols, techniques that cause much less physiological disruption. It all means that recovery profiles are just exponentially faster than they were, say, 20 years ago.
That historical marker is key.
Yeah.
I remember day surgery was pretty much limited to cases lasting less than an hour.
Right. There were big concerns about recovery time and the total anesthetic exposure.
But that's now obsolete.
Largely, yes. Modern advancements mean that procedures lasting 3, even 4 hours can be routinely and very successfully performed as day cases.
Like complex laparoscopic procedures.
Exactly. They might take longer in theater, but the reduced surgical stress and the much lower pain from the small incisions, it completely compensates for that extended theater time.
But the express lane still needs absolute guardrails, right? It can't just accept any procedure.
No, absolutely not. The source material lists 4 non-negotiable surgical criteria that dictate whether a procedure's profile is suitable, and these are essential for any learner to know.
Okay, let's detail them. These sound like the absolute gatekeepers.
They are. These 4 guardrails ensure we're not sending unnecessary risk back into home environment. So number 1, complication risk. The procedure has to carry a low risk of significant immediate postoperative complications. We are specifically worried about catastrophic events that need immediate specialized attention.
Like catastrophic bleeding or airway compromise?
Exactly. Things that require blood products and a trip back to theater or intubation and ventilation. If a procedure has a high risk of, say, an anastomotic leak or systemic sepsis, that patient needs 48 hours of mandatory inpatient observation. Period.
Okay, number 2.
Oral intake. The patient must be able to resume eating and drinking or at least take oral nutrition post-operatively before they can be discharged. If they can't stay hydrated orally, they can't go home.
Number 3 is pain, I'm guessing.
Pain management, yes.
Yes.
Postoperative pain has to be effectively and reliably managed solely by oral painkillers, maybe combined with some local anesthetic infiltration or a peripheral nerve block. This is a deal breaker.
Why a deal breaker?
Because if the patient needs ongoing parenteral administration, like a continuous IV opioid infusion, they are effectively tethered to a hospital bed.
Makes sense. And the last one?
Mobility. The patient has to be able to mobilize postoperatively, whether that's on their own or with an aid.
Yeah.
They need to be functionally able to get dressed, get to the toilet, and navigate their home environment safely.
I want to circle back to that complication risk for a second. It really speaks to the infrastructure needed. If a patient is deemed high risk for, say, an anastomotic leak, why can't we just watch them for 12 hours and then send them home?
Because the treatment for that potential complication immediately violates the other rules.
Ah, okay.
A patient you suspect has a leak needs to be kept strictly nil by mouth, no oral intake, which breaks Rule 2. They'll need continuous intravenous fluids, strong IV antibiotics, and probably high-dose IV opioids while they wait for scans or reoperation, which breaks Rule 3.
And they'll be too unwell to move, breaking Rule 4.
Exactly. You're observing for a complication that, if it happens, mandates inpatient care immediately. So you have to prevent that patient from ever entering the express lane if the risk is significant to begin with.
That makes the logic crystal clear. So if a surgeon believes their procedure meets these 4 criteria, they can confidently put the patient on the day surgery pathway.
Yes, and we have hard, auditable data on what works, thanks to the British Association of Day Surgeries, or BAD's Directory of Procedures.
And that directory, Table 22.1, is essential, isn't it? It moves beyond just theory.
It does. It gives us suggested, achievable, recommended day case rates. For example, procedures that are almost universally successful as day cases include things in orthopedics, like an arthroscopy of the knee or shoulder. They're listed at an impressive 99% recommended rate.
What about some of those procedures that are really pushing the boundaries, the ones that need sophisticated, minimally invasive techniques?
You see that breadth very clearly. Laparoscopic cholecystectomy gallbladder removal, that's listed at a 75% recommended rate.
And that's a perfect example of optimization, right? Small incisions, less pain.
Exactly. Less physiological trauma. Even in breast surgery, a simple mastectomy is listed at 75%. For ENT, tonsillectomy is high at 90%. And showing just massive strides in gynecology, even a vaginal hysterectomy is listed at 60%.
These percentages are important, though, because they acknowledge that even when a procedure is suitable, patient selection and logistics will always mean there are some failures, I guess, some patients who need to be admitted overnight.
Exactly. That 75% rate for a lap col means 3 out of 4 patients go home, but that one who doesn't might have had severe post-op nausea needing continuous IV antiemetics, or maybe unexpected pain that needed IV opioids. We always have to plan for that 25% failure rate. That's why the safety net is so crucial.
Okay, let's solidify the application of those 4 guardrails with a crucial check-in question for you, the listener.
Agreed. So consider this scenario. A 3-hour, technically challenging bowel resection is performed laparoscopically. The surgeon is confident in the technical success, but the patient is expected to require IV opioid pain control for 48 hours to manage incisional pain, and the procedure carries a standard 3% immediate risk of an anastomotic leak. Is this procedure suitable for day case surgery?
Okay, let's run the express lane check. The 3-hour duration.
Right.
We said that's acceptable now, but it violates 2 absolute rules. That 3% immediate risk of a potentially catastrophic complication, the leak, is high enough to violate rule #1, low complication risk, because the consequence is just so severe.
Right.
And requiring IV opioid pain control for 48 hours, well, that absolutely demolishes rule #3, oral pain management.
Precisely. The answer is an emphatic no. It fails on the critical criteria related to the recovery profile, even if the surgery itself is a technical masterpiece. And if you didn't immediately see that link between IV opioids and a delayed discharge, please just rewind and refresh those 4 surgical criteria. They are the absolute foundation.
Right. Surgical suitability is all about predicting the level of postoperative care required. If it needs close nursing observation and IV support, it's just not an express lane procedure.
Well, stop.
We've established the parameters of the express lane and the cargo it can carry. Now we have to look at the driver, the patient's medical suitability. Section 3 is a vital part of the chapter, and it stresses that very few restrictions should exist anymore. But we do need to talk about some of the historical barriers.
This is probably the biggest conceptual shift for many people. The source material really emphasizes that we have to move beyond outdated, arbitrary cutoffs that are based on factors that don't reflect a person's true functional capacity.
So you're talking things like arbitrary age limits or just automatically excluding someone based on their general ASA status.
Exactly. If a patient is, say, 85, but they're functionally fit and they just need a simple procedure, they're still eligible.
So age on its own is not a contraindication.
Absolutely not. And ASA status is often misunderstood. We are not automatically excluding ASA 3 patients. Suitability is judged entirely on the patient's comorbidities and their functional status.
The goal is optimization, then.
Always. The question is, can we get the patient's existing conditions well controlled enough before surgery so they can be treated as a day case?
So what's the line we can't cross with ASA status?
The line is stability and control. The one medical exclusion we have to enforce strictly is for patients who have an unstable ASA 3 status. So their hypertension or heart failure is just not controlled, or any patient with an ASA 4 or 5 status where their systemic disease is a constant threat to life.
Stability is the key word.
It is. A stable, controlled ASA 3 patient is often much safer for day surgery than a young, previously undiagnosed ASA 2 patient who turns up with severe, uncontrolled hypertension.
Okay, let's look at some specific conditions that need active optimization, starting with diabetes. As a systemic disease, it makes the whole perioperative period a bit of a tightrope walk.
It creates very specific challenges, particularly around that mandatory fasting period. The UK national guidance gives us a clear threshold here. Patients with well-controlled diabetes, and that's specifically defined as an HbA1c below 69 millimole, can be safely managed.
And what's the action plan if the patient presents with poor control? Say, an HbA1c of 95.
Well, poor control immediately elevates the risk of life-threatening cardiovascular complications, like a perioperative heart attack. And it also increases the risk of poor wound healing and surgical site infection. So the action plan has to be to delay surgery.
Until it's controlled?
Until the diabetes is electively controlled and optimized. We would liaise with their diabetologist and get it sorted first.
Does being diabetic affect their placement on the operating list on the day?
Critically, yes. We always try to schedule insulin-dependent diabetics or those on oral meds that carry a risk of hypoglycemia first on the list.
To minimize the fasting time.
Exactly. The priority is minimizing that fasting window. A diabetic patient who's kept nil by mount for 12 hours waiting for an afternoon slot is at a much, much higher risk of life-threatening hypoglycemia, or, on the other hand, severe hyperglycemia and ketoacidosis. That need for minimization is what drives their priority.
Okay, moving on to epilepsy. How do we make sure the stress of surgery doesn't trigger a seizure and compromise the express lane's safety?
Again, it's all about control. Well-controlled epilepsy is not an exclusion. The critical management point is just ensuring that the patient's normal anticonvulsant medications are not missed in the pre-op phase.
And avoiding certain anesthetic agents.
And avoiding agents that might lower the seizure threshold, yes. If their epilepsy is poorly controlled, that absolutely needs to be electively optimized before we even think about scheduling surgery.
Now, the third big medical consideration, and maybe the one that's seen the most dramatic shift in approach, is obesity. Traditionally, it was viewed with extreme caution.
And that traditional caution is being rapidly overcome. The source materials is clear that even morbidly obese patients, so a BMI over 40, can be safely managed as day cases, provided the unit has expert staff and the right resources.
Like specialized beds and lifting equipment?
Exactly. But this group requires really intense screening because of the high prevalence of underlying respiratory issues.
And this is where the Stop-Bang questionnaire comes in.
It is absolutely essential. Stop-Bang is an 8-item screening tool. It stands for snoring, tiredness, observed apnoas, pressure for hypertension, body mass index, age, neck circumference, and gender.
And it's used to identify patients at high risk for obstructive sleep apnea, or OSA.
That's right. A high score, particularly 5 or greater, means that patient is at a significantly increased risk of airway obstruction, respiratory depression, and desaturation during their recovery from anesthesia.
So how does a high Stop-Bang score actually change the anesthetic and recovery plan?
If the patient's scored highly, they get flagged as high risk. This means the anesthetist has to use extremely short-acting agents, meticulously titrate every medication, and most importantly, provide specialized monitoring in recovery.
So they might need something like CPAP.
They might need immediate access to CPAP post-extubation, and they have to be recovered in a semi-recumbent, propped-up position. This extended specialized monitoring is exactly why a high Stop-Bang score of 5 or more is listed as a SOBA red flag.
And SOBA is the Society for Obesity and Bariatric Anesthesia.
Yes.
Let's detail the other critical SOBA red flags from figure 22.2. What else forces us to pull a patient out of the express lane?
These red flags are immediate warning signs. So besides a high stop bang, we look for poor functional capacity.
Sure.
If they can barely walk a short distance, their physiological reserve is poor. Another hard rule is low oxygen saturation, less than 94% on air. And of course, uncontrolled coexisting diseases like severe hypertension.
And there's a specific biochemical marker in there too, isn't there,
Pretty cool.
related to respiratory function?
Yes, the bicarbonate level. If the patient's bicarbonate is found to be greater than 27, it suggests they've compensated for chronic respiratory acidosis.
Which is a strong indicator of what?
A strong indicator of obesity hypovolation syndrome, or OHS. And OHS patients are extremely vulnerable to respiratory depression after an anesthetic. They should almost certainly be managed as inpatients and often need pre-op blood gases or even a formal sleep study.
So the whole strategy for those obese patients who are suitable short-acting anesthetics, avoiding long-acting opioids, it all points back to guaranteeing the integrity of their airway.
It does. We optimize, we assess their functional status rigorously, and we rely heavily on objective tools like stop-bang. We're replacing arbitrary exclusions based on BMI with calculated individualized risk assessments.
Okay, let's apply this in a quick case study just to test the medical suitability rules we've covered.
Great idea. So, case scenario. A 78-year-old patient with stable ASA3, hypertension, and controlled type 2 diabetes, their HbA1c is 65, needs a simple knee arthroscopy. They live 45 minutes from the hospital. Their stop-bang score is 3. So based on the source material, is this patient a suitable day case candidate, or are they automatically excluded by their age or ASA status?
Okay, let's analyze the flags against the principles of the express lane. The patient is 78, but the chapter explicitly says age is not an arbitrary cutoff.
Correct.
They're ASA3, but it's stable ASA3, which is allowed. We only exclude unstable ASA3s. Their diabetes control, an HbA1c of 65, is well below the 69 exclusion threshold. The procedure itself, a knee scope, is 99% recommended for day surgery. Socially, the 45-minute drive is fine. And crucially, their OSA risk is low. A stop bang of 3 is well below that red flag threshold of 5.
So the conclusion is that they are suitable. The learner have to internalize that suitability rests on controlled comorbidities and functional status, not simple demographic markers. It requires the whole MDT to look beyond the number and assess the physiological reality of the patient in front of them.
Okay, suitability checked and confirmed. Now we need to look at the logistics of the express lane, the environment the patient is actually going back to, and the physical facilities themselves. Section 4 kicks off with social criteria, which can often create these unexpected blockages.
Oh, social factors are absolutely non-negotiable gatekeepers. A successful recovery relies on a safe home environment. We have 3 main logistical requirements.
What are they?
1, infrastructure. This means adequate housing conditions, so heating, an inside toilet, and access to a functioning phone, whether it's a mobile or a landline. It sounds basic, but it's vital for hygiene, comfort, and follow-up.
2 is proximity.
Proximity, yes. The patient must live within a 1-hour drive of a hospital. That 1 hour is key. It defines the window within which professional help can be accessed in an emergency. And note, it doesn't have to be the surgical hospital, just a facility that can handle immediate complications.
And number 3 is the big one.
Number 3 is the anchor rule. Supervision. A responsible adult must be able to stay with the patient for a mandatory 24 hours after they've had a regional or general anesthetic.
Let's spend a bit of time on that responsible adult rule, because this is where the practical barriers really start to show up. What does responsible truly mean in this context?
It means the individual has to be capable and competent. So they can't be another patient who's also recovering from surgery, nor can they be someone who's intoxicated, cognitively impaired, or unable to physically assist the patient if they need it.
Because after a general anesthetic, the patient might be sleepy, nauseous, transiently confused.
Exactly. The responsible adult has to be able to monitor their breathing, give them their medication safely, and be able to spot red flags like heavy bleeding or uncontrolled pain, and then call the emergency contact number they were given.
And this can be a massive barrier for single people, the elderly living alone, or people whose family members work complex shift patterns.
It creates a huge social barrier, and this is where the chapter notes that surgical thinking is actively evolving to ensure everyone has equitable access to the express lane. This barrier has actually spurred some real innovation in the UK to solve the problem.
Right, we mentioned the Torbay model.
Yes, the Torbay and South Devon model is fascinating. They tackle the problem by physically providing the solution. They arranged and paid for carers to go to the patient's home to fulfill that 24-hour supervision role.
And the second model from Norfolk and Norwich sounds like it uses risk stratification to actually relax the rule in very specific cases.
That's the Norfolk and Norwich University Hospital model. They developed a really sophisticated home alone flowchart for extremely low-risk, compliant patients who are having very minor procedures, usually under local anesthetic or maybe mild sedation. It allows them to go home without a physical care, but only after they pass a very stringent final checklist.
And both models have been shown to be safe.
Both models have reported excellent patient satisfaction and, crucially, no adverse outcomes. It just demonstrates that we can safely adapt these social criteria if we have robust planning in place.
Okay, moving on to the facilities. You stressed earlier that for the express lane to work, you can't have the staff being constantly pulled into the inpatient gridlock. National guidance recommends dedicated infrastructure.
Absolutely. The guidance strongly recommends operating a dedicated unit with its own admission area, its own operating theaters, and a dedicated discharge ward. At an absolute minimum, a separate, dedicated day surgery ward is essential.
And this separation is what you called the efficiency engine?
It is. It's from Table 22.3, and the operational differences it provides are huge.
What are they?
Multiple benefits. First, focused expertise. The nurses, surgeons, and anesthetists, they're all specialists in the day case process. That leads to faster assessment, higher skill in managing rapid recovery, and quicker decision-making.
It also gives you scheduling independence.
Yes. The unit's activity is protected. It can keep running even when the main inpatient wards are full or facing bed pressures. That drastically reduces cancellation rates, which plague acute lists.
And then there's the equipment and the workflow.
It's all geared toward turnover. Dedicated recovery bays, specialized equipment, a focused workflow, and there's a psychological benefit too.
How so?
The separation is powerful. Patients see the discharge ward as the norm, not some temporary holding area. This environment encourages them to get up and about, to take drinks early, and it creates an expectation to go home. That drives successful discharge rates up.
And there's a safety aspect.
A huge one. Dedicated units can be easily designated a COVID-secure or green pathway, protecting elective patients from infectious parts of the acute hospital.
Okay, this emphasis on separation and expertise seems to be the central pillar for avoiding that gridlock. Let's talk about the actual flow. Preoperative assessment and list planning.
The assessment has to follow standard nurse-led principles, but with a really sharp focus on day case-specific criteria. The team's role here is highly interpretive. Key specific points are confirming that 24-hour responsible adult is in place and an active check. Can surgery be delayed to optimize a medical condition?
Delaying surgery for optimization, that sounds like the hallmark of prioritizing safety over speed.
Precisely. If a patient's blood pressure is 220/120 or their HbA1c is 100, the risk of rushing them through the express lane is just too high. The anesthetist review at this stage is often the final green light, confirming they meet all those medical suitability rules we discussed.
And then list planning. That's the ultimate traffic control on the day, isn't it? Table 22.4. Order matters.
It matters significantly to maximize throughput and minimize risk. We aim to place operations or patients who need longer recovery times.
Like tonsillectome patients who need 6 hours of observation.
Exactly. Or elderly patients, high BMI patients, or a complex lap col. We put them early on the list. We want them in theater first thing so they have the maximum number of daylight hours to recover and meet the discharge criteria.
But you have to balance that with prioritizing patient vulnerability, even if their procedure is shorter.
Absolutely crucial. Vulnerable patients must be prioritized regardless of their predicted recovery time. This includes patients with insulin-dependent diabetes who struggle to fast for long, or patients with learning difficulties who get very anxious with prolonged waiting times.
Because the stress of waiting can actually destabilize them.
It can. It can increase their risk of needing an overnight stay.
Finally, the technique in the operating room. Surgery and anesthesia, the fast-acting fuel for our express lane.
Well, the surgical technique itself is still high quality, but the approach has to be appropriate for rapid recovery. So, minimal retraction, meticulous hemostasis, and a real reluctance to use drains.
And if drains are absolutely required.
Then there must be clear, documented, and practiced plans for their immediate removal, or specific instructions for the responsible adult on how to manage them to ensure they don't hold up the discharge.
And the anesthesia, that's the speedy recovery formula.
It's the absolute key to a rapid discharge. Requires a multimodal approach. This means combining pre-medication, like antiemetics and anxiolytics, with short-acting general agents.
Like propofol infusions or newer volatile agents?
Yes, and local anesthetic infiltration at the surgical site, and potentially regional blocks like short-acting spinals.
Mm.
The goal is complete pain relief without relying on systemic opioids.
And what's the major warning sign for anesthetic agents? We need to really hammer this point home.
We must strongly discourage the use of long-acting systemic opioids, particularly intravenous morphine, in the immediate post-operative period for day cases. They are, frankly, discharge poison. They severely delay recovery because they induce sleepiness, which violates the cognitive criteria for discharge, and they massively increase the risk of post-operative nausea and vomiting, or PONV. If a patient is asleep or vomiting, they can't be discharged. They've stalled the express lane.
We've reached the final phase. The patient meets the criteria, the surgery was successful, and we're preparing for that safe exit. Section 5 is all about the discharge criteria, the definitive green light checklist. Table 22.5.
And the mentality here is crucial. The expectation must be that the patient is going home unless there's an unexpected deviation. The process is routinely nurse-led, which really emphasizes the high degree of specialized expertise and trust we place in the day surgery nursing team. They are the final gatekeepers.
Okay, let's break down the criteria into the 3 logical groups we established for you, the listener: physiological stability, functional status, and cognitive and logistics.
Perfect. This checklist has to be ticked off before the nurse can give that final green light. So, 1. Physiological stability.
Which means
Vital signs must be stable and within acceptable limits for at least 1 hour. There has to be minimal nausea, vomiting, or dizziness, and minimal bleeding or wound drainage. We need to see that the patient has fully emerged from the anesthetic.
Okay, then functional status.
Functional status. The patient has to be able to dress themselves and mobilize post-surgery with or without an aid. They must have successfully taken and kept down oral fluids.
And there's a critical part of functional status here.
Yes. The patient must have passed urine, if it's appropriate for the procedure. And thirdly, cognitive and logistics. The patient has to be correctly oriented. They must report adequate pain control based on their oral analgesia, and they need a confirmed supply and a clear understanding of how to use those take-home painkillers.
And the final logistical checks.
The responsible adult has to be confirmed as present and ready. And finally, the patient must receive comprehensive written and verbal instructions, including that all-important emergency contact number.
Let's focus on that past urine criterion for a moment. Why is this so critical, and what procedures specifically mandate this check?
This is vital because anesthesia, particularly regional anesthesia like a spinal or an epidural, combined with the surgical trauma of certain procedures, can cause urinary retention.
So the bladder fills up, but the patient can't empty it.
Correct, and it's incredibly painful and potentially damaging. This criterion is mandatory for any procedure involving the groin or pelvis. So think inguinal hernia repairs, anorectal surgery, or gynecological procedures. If a patient can't pass urine within a defined recovery period, they'll need a catheter and subsequent observation, which instantly fails the discharge criteria.
And regarding the logistics, that emergency contact number needs to be more than just a helpline.
Absolutely. The number you give them must connect them to a suitable, live person, a nurse or a doctor who can advise them immediately, not an answer phone or a general switchboard. This ensures they get immediate access to professional support if, for instance, their pain medication isn't working or they have some unexpected bleeding.
And to make sure the express lane avoids delays at this point, the medication prescription process has to be really efficient.
Speed meets safety in prescribing. Take-home medications must provide adequate pain relief and should ideally include a rescue antiemetic. The chapter specifically recommends prescribing these medications while the patient is still in theater the moment the case finishes.
And using prepacks of common analgesics.
Exactly. This minimizes the time a nurse spends waiting for the pharmacy to dispense, which can dramatically reduce discharge delays.
Finally, the safety net extends to the next day. The follow-up call isn't optional, is it? It's essential for both the patient and the system.
All-day surgery. Patients should be telephoned the day after their surgery. This is dual purpose. Clinically, it provides crucial patient support. It lets them troubleshoot issues like unexpected pain, constipation, or just anxiety.
And systemically.
Systemically, and this is so important for you to remember for audit purposes, it collects valuable data. This data tracks readmission rates, incidence of PONV, compliance with medication, patient satisfaction. And the hospital uses all of that to refine and continuously improve the day surgery pathway itself. It ensures the express lane is always being optimized. Okay, we focus heavily on planned elective surgery, but what about acute care? Section 6 explores emergency day surgery, running an express lane for unexpected urgent incidents. This seems a bit counterintuitive, as acute patients are often less optimized.
It does seem counterintuitive, but it's highly necessary. The reality is that many emergency surgical procedures are minor and non-life-threatening.
You're thinking of things like simple hand trauma or common abscesses.
Exactly. The problem is that these patients are often deemed low priority compared to major traumas or ruptured aneurysms, so they face prolonged waiting, unnecessary starvation times, and a lot of frustration while they wait for a slot on the main emergency theater list. It's just grossly inefficient. So the opportunity here is to create an acute bypass pathway for these low-risk acute cases.
Exactly. With appropriate rapid risk stratification and planning, these acute patients can utilize an emergency day case pathway. This is already common practice in orthopedics for a lot of upper limb trauma, in gynecology for things like an ERPC, and it's increasingly being used in general surgery.
And the BDES directory is expanding to include these emergency cases as well in Table 22.6. Can you give us some high-yield examples that show the scope?
Yes, we see procedures with very high success rates. Evacuation of retained products of conception is suggested at a 95% day case rate. Incision and drainage of a perineal abscess is also at 95%. Even slightly more complex trauma, like the repair of hand or wrist tendons, is suggested at 95%.
I did notice that appendicectomy is listed, which traditionally demands an inpatient stay, but it's at a much lower suggested rate.
It is included, yes, but only at 15%. This acknowledges that while it's technically feasible, only a very small subset of patients are suitable.
The ones with non-complicated early-stage localized inflammation.
Correct. The ones who are systemically well and don't need significant fluid resuscitation or IV pain control. For the vast majority, the risk of developing systemic complications or needing significant parenteral support pushes them firmly into the inpatient category. That low percentage is a critical piece of data there.
If the acute patient's procedure can wait a bit, say a scheduled reduction of a fracture, what pathway does that patient follow to get onto the express lane?
If the procedure can wait more than 24 hours, the patient can follow a kind of hybrid elective pathway. They can be triaged rapidly, swabbed and isolated if needed, and then attend via an elective green pathway, which protects them from the main emergency flow and all its delays.
And what if they have to wait longer, but they're clinically stable?
In that scenario, the ultimate acute bypass strategy can be used. If it's appropriate and they're stable, they can be discharged home, and then return later to an acute surgical admission area for a priority slot on the emergency list, still aiming for a same-day discharge.
Which prevents the patient from blocking an emergency bed and reduces their fasting time while they wait comfortably at home.
Exactly. It's much more efficient.
But we have to ensure the same strict rules about medical and social suitability still apply, especially the contraindications to emergency discharge.
Absolutely. The express lane rules don't just disappear because the case is acute. We have to identify the absolute red flags that stop an emergency patient from going home. Things like systemic sepsis, unstable diabetes that we can't optimize rapidly, or major comorbidities that weren't controlled.
Or if they need ongoing IV pain relief.
Or if they need ongoing parenteral pain relief, that's a big one. They must have continuous IV pain medication. And additionally, if the patient is deemed unsafe to mobilize, or if that required responsible adult can't be secured, they have to remain an inpatient. These red flags protect the integrity and the safety of the acute bypass pathway.
That brings us to the end of a very detailed deep dive into Baily and Love, Chapter 22. The Day Surgery Express Lane is really a masterclass in efficiency that's built on a foundation of uncompromising safety. We've established that precise patient selection covering the surgical profile, their medical stability, and the social infrastructure acts as the stringent gatekeeper.
And that dedicated facilities provide that high-throughput efficiency engine. Meticulous anesthesia, combined with rigorous discharge planning, is what guarantees that safe exit home.
To summarize the critical points we anchored today, your revision checklist before you go back to the text.
1. Day surgery is defined strictly by going home the same calendar day. A 23-hour stay classifies the patient as an inpatient.
2. ASA status, specifically stable ASA 3 and age, are not arbitrary cutoffs. Function and the control of comorbidities are the critical determinants of suitability.
3. The Stop-Bang score and the SOBA flags are essential screening tools for assessing high BMI patients, primarily checking for obstructive sleep apnea or obesity hypoventilation syndrome.
4. The 24-hour responsible adult rule is essential, but we saw how innovative models like Torbay and Norwich are evolving safe, equitable solutions to bypass this social barrier.
5. Avoid long-acting systemic opioids like IV morphine. They are the fastest way to induce sleepiness and nausea, stalling recovery, and failing the discharge criteria.
And finally, 6. The passing urine check is critical for all lower abdominal, groin, and pelvic procedures to rule out painful and dangerous urinary retention.
We sincerely hope this interpretive guide serves you well. You now have the anchors, the structural roadmap, and the case examples to really solidify this exceptionally high-yield topic.
And I'll leave you with a final provocative thought, building on the success of those evolving UK models that are addressing the responsible adult requirement. The safety of day surgery hinges on ensuring the patient is monitored for 24 hours after a general anesthetic.
So considering the rapid advancements in remote monitoring technology, wearable sensors that track heart rate, respiratory rate, movement, coupled with real-time telehealth check-ins, how might future surgical pathways leverage this technology to safely expand day case suitability even further?
Could we perhaps bypass the necessity of a physically present carer in highly compliant, low-risk situations?
And in doing so, make the express lane accessible to an even wider demographic.
That is the technological path the express lane must take to evolve and remain the standard of care. Thank you for diving deep with us today.
We look forward to seeing you back here soon.